Hello everyone, Dr. Alex Vasquez here. Today, continuing our conversation on this clinical review of vitamin D deficiency in adults. This is part 4 on inflammation, coagulation, and immunomodulation, which might also be subtitled Looking for Signal Among Noise, Deepening Our Understanding from 2004 to 2021. The 4 main conversations in today's review will include some background and considerations. For example, I'm going to talk about hypercoagulation, but I'm sure that most people probably haven't studied hypercoagulation, so we at least need to have some orientation to that topic. After that, we'll look at some rejected data, some data that's really not worth our consideration, but I'll show you why it's not worth our consideration. And then we will move on to the main course of 23 clinical trials, plus excerpts and reviews, and we'll look at data from several thousand patients. I'm just guessing it probably includes about 15,000 patients. And then I'll provide a summary and closure. So whenever you see this mauve background, that means that we are transitioning from one of these groupings into the next. Let's start by looking at a few quiz questions that might help us kind of get oriented to the level of competence that we might aspire to. So for example, we might ask, like, what are the best ways to administer vitamin D for the prevention of chronic illness versus acute illness? We might look at some parameters, and we might review some of the information that I already talked about in videos 1, 2, and 3. For example, information specific to chronic pain and pain amplification, as well as anxiety, depression, and neuroinflammation, as well as barrier defenses. Also, the interpretation of lab tests, of course, is very important, so I emphasize that here in question number 11. And of course, anytime you want to pause the video and kind of deepen your understanding of the information, you're certainly welcome and indeed invited to do that. I would like to be able to present this information to you, but if I take the time to read and explain everything word for word, then of course that would turn a long video into an all-day presentation, and we certainly can't afford that time in this setting. So what I would invite you to do is anytime you're interested in learning more, just pause the video, read things word for word, think about it, and then that will help you deepen your understanding without me having to kind of go through the nuances of those conversations within today's video setting, which again, let's assume that I can do this within 1 hour. If I explained everything word for word, that would probably take us at least to 4 hours. So I'll invite you to kind of achieve the level of study that you're comfortable with. As I'm sure you know, we've been looking at this vitamin D and inflammation and disease treatment and prevention model now for at least 17 years. And over the course of that 17 years, we would naturally expect things to kind of mature and develop. So the answers that we had back in 2004, pretty much by definition, need to be different from those answers that we might have now by taking a fresh look at the information. And indeed, that's the case. I think our overall conclusion will probably be the same, but we'll have more nuance and a deeper appreciation of the advantages and disadvantages and limits and the clinical applications of this information. So I invite you to stay tuned as we walk our way through this information. I'm going to focus here on citations just to give you, of course, the source of the information. We'll look at what they actually did, and then we will see what test results actually changed. So in most of the studies, we're looking at inflammatory markers and how those changed in response to what we hope is competent vitamin D supplementation. And sometimes they did or didn't look at clinical effects. A lot of times these studies were just looking at inflammatory markers. Sometimes we have clinical effects without the inflammatory markers, and more often the reverse. So we'll try to put that into context, and then we'll try to put that into a larger context of all of the information and kind of look for patterns so that we can appreciate what's going on overall and what we can expect when we're working with actual patients or conducting research. In preparation for today's presentation, I reviewed a large amount of information, and whenever I have to organize a large amount of information, I try to give it a structure, even if it's just a simple acronym to help me stay organized. And the one that I eventually settled on was CITES, which is Citation, Intervention, Tests, Clinical Effect, and then the summary. So that's the structure that I will use as I review today's information. So I had hoped that over the intervening 17 years since we published the vitamin D monograph in 2004, I had hoped that the evidence would be very clear and actually a bit simplistic, if I must say, because I was looking for basically a continuation of this level of research, which was published back in 2002 in Quarterly Journal of Medicine, showing that vitamin D supplementation could actually alleviate this subclinical excess inflammation. This was actually a beautiful and elegant study But by today's standards, we might question some of the ways that this study was designed, implemented, and measured. For example, the dose of vitamin D that they actually used was very low, and therefore the serum response was very low. And even though this data supports the general idea that vitamin D has an anti-inflammatory effect, it's certainly not consistent with what we would consider good practice in clinical nutrition these days. So we'll look at the study again later, but I wanted to show you this example of what the data looked like earlier versus what the data looks like now. And I think these days we actually have more robust data to extend this into a better understanding of how vitamin D functions, and also how to explain some of the inconsistent results that we see with very low levels of vitamin D administered to patients who are very vitamin D deficient. And again, I'll talk about the details later when we look at this study again. One of the things they found in this study of very deficient patients who were given low doses of vitamin D is that their fibrinogen levels actually increased slightly. And I'll be happy to provide you an explanation for why I think that happens. And I think it has to do with stimulating generalized protein synthesis in these patients who are severely vitamin D deficient. And I'll explain that more with some diagrams in just a few moments. As I've said from the start of this series on vitamin D deficiency in adults, I really think that vitamin D deficiency in adults needs to be redefined now, because many of us who grew up reading Robbins' Pathologic Basis of Disease were only taught that vitamin D deficiency in adults presents as osteomalacia, which first of all, most doctors don't know how to diagnose clinically, and second of all, that really misses the grand picture of the complications that result from vitamin D deficiency. So I've already talked about chronic pain and pain amplification. We've also talked about mood disorders, depression, and anxiety. In part number 3, I talked about impaired barrier defense, which increases the risk for infections, and also autoimmune conditions and allergic conditions. And right now we're talking about inflammation. So we need to get away from the idea that vitamin D deficiency in adults only presents as osteomalacia. We're going to see that the consequences are much grander than that and much more common than that. And that's yet another reason why vitamin D deficiency needs to be treated instead of just assumed, I guess, to be somewhat normal, because it's not normal. And I think this underscores the urgency for treating vitamin D deficiency in the prevention of pain, mood disorders, impaired barriers and infections, and disorders of excess inflammation. So let's say that a patient acquires a viral infection due to number 3, impaired barriers here. And because of their impaired barriers, they're more vulnerable to the infection. And then when they get the infection, they have more inflammation and less modulation or control of that inflammation. So they're more likely to enter into a virus-induced cytokine storm, which can have fatal consequences, including acute lung injury and acute respiratory distress syndrome. So in those situations, are we going to blame an otherwise benign virus, or should we look farther upstream to the nutritional deficiencies that led to the vulnerability to that otherwise benign viral infection? I think the data is very clear that we need to be looking upstream to the nutritional deficiencies that make some people vulnerable to what would be otherwise a benign viral event. So again, today's focus is going to be mostly on inflammation, but anytime we talk about inflammation, we also have to talk about coagulation. And whenever we talk about inflammation and immune function and barriers and coagulation, we then end up talking about cellular defense, barrier defense, what I call here protein defense, which includes antibodies and antimicrobial peptides. But of course, we have to balance that conversation by looking at immunomodulation and immune tolerance. Anytime we look at all those together, we end up talking about the microbiome. We also talk about metabolism and mitochondria, both of which are influenced by vitamin D and, of course, other nutrients and dietary patterns. We talk about nutrients working synergistically together, but nutritional deficiencies also function synergistically to promote negative outcomes. So, for example, let's say that 60% of people worldwide are deficient in vitamin D, 30% are deficient in zinc, and 15% are deficient in selenium. What happens to those people who are deficient in zinc, selenium, and vitamin D? Obviously, they're going to be more vulnerable to otherwise benign infections, especially viral infections. And that's an example of where we could really have a public health and global health impact through the use of safe, affordable, and readily available nutritional supplementation. Again, when we talk about vitamin D supplementation, we can also talk about neuroinflammation of the hypothalamus, neuroglia, and the effect that that has on the vagus nerve and overall metabolism and inflammatory balances. We can talk about hormones, cytokines, and neurotransmitters. And we can appreciate that nutritional status has a bidirectional relationship with psychosocial events. So, for example, when people are nutritionally deficient, they're more likely to have depression, anxiety, and other mood disorders. So that affects their psychosocial interaction, and the psychosocial and political climate that we live in also determines our nutritional status through food availability and either accurate news or what we might call fake news within nutrition and medical news, which all too commonly discourages people from pursuing appropriate nutritional supplementation. The relationship between psychosocial influences and nutritional status is, of course, bidirectional, because when people are nutritionally deficient, they're more likely to have mood disorders such as anxiety, depression, and aggression. And depending on the psychosocial and political climate that we live in, people might be encouraged to eat junk food, or they might be discouraged from using nutritional supplements. And of course, then that creates a vicious cycle for negative psychosocial impact. And of course, all the while, we are living in a toxic environment loaded with metals and xenobiotic chemicals. So again, I'm going to focus today on inflammation, coagulation, and maintenance of immune tolerance via what I call nutritional immunomodulation, which is one of the protocols in my book, Inflammation Mastery. I think that overall we've given too much attention to inflammation and not enough attention to barriers and immunotolerance. So today we're going to balance out that conversation a bit, and we're going to focus on not simply inflammatory markers, but also anti-inflammatory markers, and how we can change immune phenotype through the use of nutritional supplementation. And again, I discussed that in Chapter 4 of Inflammation Mastery 4th edition, and that's what I call the Nutritional Immunomodulation Protocol, and I'll show you a few excerpts and diagrams from that section later in today's presentation. On the following page, I provide a quick list of the inflammatory markers that we consider most commonly. These are CRP, interleukin-6, interleukin-1, tumor necrosis factor alpha, fibrinogen, and interleukin-10, which is the uniquely anti-inflammatory cytokine. We all know about the common causes of inflammation, and we're not expecting vitamin D to perform as some miracle anti-inflammatory agent. So, for example, if a patient is obese and they continue smoking, then of course they're going to have ongoing problems with inflammatory complications. But even in those situations, vitamin D may provide some amelioration of their excessive inflammatory response. So what we're trying to do is address the vitamin D component and perhaps also the microbiome component of their inflammation by using vitamin D supplementation if they are deficient in the context of having excess inflammation. Excess inflammation couples with excess coagulation for reasons that I explain on this page. But again, we're not expecting vitamin D to function as an anticoagulant. What we're trying to do is normalize situations of excess inflammation attributed to vitamin D deficiency and its consequences, such as obesity and gastrointestinal dysbiosis, both of which are influenced by vitamin D status. Here you can read a few more ideas if you want more details, but let's look at some of the risk factors for thrombosis, deep vein thrombosis, pulmonary embolism, and venous thromboembolism. Many of the risk factors for thrombotic complications are genetic, so we often consider factor V Leiden mutation, hyperhomocystinemia and homocystinuria, prothrombin mutation, and also anticardiolipin and antiphospholipid antibodies, which are seen in various autoimmune conditions. So again, this is a listing of some of the major risk factors for thrombosis and venous thromboembolism. We're not expecting these to be alleviated by vitamin D supplementation. On this page, I list some of the laboratory and analytic considerations when assessing inflammatory balance. Prior to developing this particular presentation, I was already starting to develop the impression that vitamin D deficiency, especially more severe vitamin D deficiency, could induce a state of anti-anabolism or catabolism. And I think the best example of this is when we look at elderly patients with vitamin D deficiency who have sarcopenia and also cognitive decline, which can be interpreted both as measures of impaired protein synthesis. And I think that might explain why we see a slight increase in fibrinogen levels when people are severely deficient and they're only partially repleted with vitamin D. So, for example, as I show here, what we see in patients who are severely vitamin D deficient, when they are given vitamin D, their fibrinogen levels actually increase slightly. And I'm proposing that that might be due to the initiation of global protein synthesis, not necessarily a pathologic response, but just that their bodies are actually able to function again now that they're a little more nutritionally replete. So again, what I'm referring to specifically here are the two studies that show that in patients who are very vitamin D deficient, giving them vitamin D actually causes a slight bump in their fibrinogen levels, a slight bump upwards, and then things normalize later. which again is why we have to look at the overall pattern of the research and the overall pattern of the clinical effects, not just look at these outlier studies where they use very low dose in patients who are very vitamin D deficient. So again, transitioning patients from an anergic and catabolic state into normal physiology appears to induce a slight increase in their fibrinogen production, at least at the start of nutritional repletion. Very quickly here, I'll talk about the vicious cycle of vitamin D deficiency, and that is when people are vitamin D deficient, that puts them at higher risk for inflammatory and infectious diseases. When they develop those inflammatory and infectious diseases, that actually depletes them of vitamin D, and that creates a vicious cycle. So I think this is what we see with vitamin D, and for sure this is what we see with vitamin A. So the vicious cycle is actually more established with vitamin A than it is with vitamin D, but I think it applies to both. Nutrient deficiency predisposes to infection and excess inflammation. Then those infections and excess inflammation actually cause nutrient depletion, and that exacerbates the original nutritional deficiency. So again, this is the vicious cycle of nutrient deficiency, predisposing to disease. Then the initiation and development of that disease actually causes more nutritional depletion, which makes them vulnerable again. And as I mentioned previously, we also see this with zinc and protein deficiency. So again, nutritional deficiency leads to vulnerability. Vulnerability leads to infection and inflammation. Infection and inflammation further depletes nutritional status, and that leaves people in a worse situation than when they started because now they are more nutritionally depleted, and that creates this vicious cycle of zinc and protein deficiency, also vitamin A deficiency, and I believe also vitamin D deficiency. Let's take one more look at this concept here when I talk about crisis-induced depletion of vitamin A. So when people are acutely ill, especially with an inflammatory condition such as an infection, like a viral infection, the classic example, of course, being measles, when they become acutely ill, they actually lose vitamin A due to changes in renal handling and protein metabolism. That leads to epithelial failure in the respiratory tract as well as in the gastrointestinal tract, and that vitamin A depletion then leaves them vulnerable to ongoing or recurrent infections as well as inflammatory complications of those infections, because when they lose vitamin A, they also lose the ability to generate those modulating or anti-inflammatory T regulatory cells, and so this becomes a vicious cycle of one crisis after another. And I'm quite sure that this explains some cases where patients get ill and have a hard time getting out of that vicious cycle until they are nutritionally repleted. And not only with vitamin A, but also with vitamin D, zinc, protein, cysteine, and other nutrients. Very quickly here, before we get into the main course, I'll show you 4 studies that I rejected, and I will show you why I rejected them. This study used a very unusual type of vitamin D. Even though they called it vitamin D3, it was actually 1-alpha hydroxyvitamin D. That's not clinically available, and it's certainly not the clinical standard of use. This study was absolutely ridiculous. They used a bolus dose of ergocalciferol, which is absolutely horrible, and then they concluded that vitamin D didn't raise vitamin D levels. I think that that's completely absurd. The following study also used bolus dosing, and they really didn't show much of a deficiency-sufficiency differential, and so their results were not very robust. They did not look at inflammatory markers, but they did show a slight improvement in glycemic tolerance. And the final study here that I rejected is simply an observational study. It's not a clinical trial. What they showed here is that neonates with vitamin D deficiency have more inflammation as measured by C-reactive protein. But again, this wasn't an interventional trial, so it doesn't really tell us much about the causal relationship between those two variables. It just shows us that vitamin D associates with more inflammation, but it doesn't tell us why, and it really doesn't inform clinical practice. So now I'm going to focus on the 23 clinical trials and reviews that do enlighten clinical practice. All of these, again, are clinical trials in humans using hopefully at least reasonable doses of vitamin D, and I'll explain that as we go through. And we'll look at data from several thousand patients. We're going to start with this first article from 2002 that I mentioned previously. This was published in the Quarterly Journal of Medicine, and what they did here is give kind of a low dose of vitamin D. They gave an intramuscular injection of 50,000 international units once every 3 months. So that comes out to about 500 international units per day, which of course is not consistent with good clinical practice these days. But nevertheless, what they showed here is a 68% reduction in MMP9, which is an inflammatory marker and an inflammatory mediator as well. Also a 23% reduction in C-reactive protein. This marker here, TIMP1, is actually kind of an anti-inflammatory kind of counter-regulatory marker. So even though it's anti-inflammatory, it did reduce, but it reduced because these other markers were modulated with the vitamin D. What they showed here is what I mentioned previously. They showed a slight increase in fibrinogen, and for me that was unexpected, but I think it could be explained by the initiation of protein synthesis by taking these patients from being horribly deficient to actually less horribly deficient. So they were very low at 8 nanograms per milliliter. With treatment, they came up to 14 nanograms per milliliter, which is still horribly deficient. The authors here did not look at any clinical effects, so my summary of this study is vitamin D supplementation, even very weak supplementation, reduces markers of inflammation, MMP9, TIMP1, and C-reactive protein, with a paradoxical slight increase in fibrinogen, no measurement of interleukin-10. The dose of vitamin D in this study was minuscule and certainly not consistent with modern clinical practice, although it was appropriate for the pre-2004 era. So again, this was published in 2002, which means they collected the data prior to that. I actually think they had a 5-year follow-up in one part of the study here, which means they would have started the study at least in 1996, maybe 1997. So for that era, this was a very appropriate study, even though, again, it wouldn't be consistent with clinical practice these days. Nonetheless, we do see clear evidence of anti-inflammatory benefit by seeing reduction in all of these inflammatory markers. Let's look at a more modern study here. This is from American Journal of Clinical Nutrition, 2006, so a little bit more advanced in terms of getting over the threshold that we crossed starting in 1999 with Veith's article, and then the Zitterman article in 2003, and the Robert Heaney article in 2003 as well, and then my article in 2004. So here we are now, 2006. In this study, they gave approximately 100 patients 2,000 international units of vitamin D, and what they showed here is a normalization of parathyroid hormone, which shows that the vitamin D supplementation actually worked, and they also showed an increase in the anti-inflammatory cytokine interleukin-10. They didn't identify any major clinical benefit from this, but nonetheless, they did show an increase in this anti-inflammatory cytokine interleukin-10. Giving these patients with heart failure 2,000 international units, I think, is absolutely inadequate, and these patients also received calcium, which would have been expected to block their magnesium absorption. So again, I don't think this study is consistent with good clinical practice, but I also think it's worth citing. At 2,000 international units, which is really too low, they did show an anti-inflammatory benefit by raising interleukin-10. So yes, we see some benefit here, but it's not consistent with modern clinical practice. So now let's take a look at this study. This was published in 2006, and again, they underdosed the intervention, and that's why we see kind of a wobble, so to speak, in their clinical results. This is from Journal of Nutrition, Health, and Aging in 2009. The intervention that they used was either 0, 400 international units, or 1,200 international units. All of those are too low. They showed a reduction in PTH, but inconsistent changes in C-reactive protein and fibrinogen. And again, when these patients were so deficient, you can see here, they started out horribly deficient, and with 400 international units, they were still very deficient at the end of the study, and even the patients who received 1,200 international units per day were still very deficient at the end of the study. So this study in no way represents modern clinical practice and supplementation with vitamin D. It may have been appropriate for its time, but I still think the doses were way too low for us to receive really good data from this study. The authors acknowledge that their power calculations were not originally made for markers of inflammation. They also state that fibrinogen was measured in a relatively small number of patients and that they needed a larger sample size to determine clinical and statistical significance. So again, I'm including this study for the sake of completeness, but it really doesn't provide us the quality of data that we need in order to inform modern clinical practice. Now let's look at a better study which was published in 2012. So remember, our entire view of vitamin D was changing during these earlier years. Let's say between 2000 and 2010, a lot of things were changing in the way that we perceived vitamin D and the doses that we were using. And I think that you see that represented in this study. So this was a double-blind, placebo-controlled intervention giving 1,000 international units per day to infants. And that's not optimal, but it's a reasonable dose for infants. After 12 weeks of intervention, vitamin D supplementation, again at 1,000 international units per day for these infants, caused a marked increase in their vitamin D level and interleukin-10 levels. Also, this resulted in decreased PTH, as we would expect, and a reduction in interleukin-6 and tumor necrosis factor alpha. Clinical benefits included significant improvement in the heart failure score, significant improvement in the left ventricular end diastolic diameter, also the end systolic diameter, the left ventricular ejection fraction percentage, and the myocardial performance index. So my summary of this study is that it shows amazing clinical and biochemical improvements in infants with heart failure who received 1,000 international units per day. They could have easily justified 2,000 international units per day per an article published in The Lancet in November 2001, and we'll take a look at that study in just a moment. So before we leave this study, let's just take a look very quickly at some of their parameters in the patients before intervention, after 6 weeks of intervention, and 12 weeks of intervention. You can see that their heart rate reduced from 154 to 130 to 124. The heart failure score reduced from 9 to 7 to 6. That's great. Ejection fraction percentage increased from 36 to 49 to 52. That's also quite good. Parathyroid hormone reduced from 40 to 32 to 28. 25-hydroxyvitamin D increased from 13 to 22 to 32, so they just about reached normalcy. Interleukin-10 levels increased from 1.25 to 1.65 to 1.85, while the interleukin-6 levels decreased from 30 to 19 to 16. Also a slight decrease in the TNF-alpha from 13.4 to 12.6 to 12.3. So again, overall, good biochemical and clinical benefits in this study. Title of this study is Impact of Vitamin D Supplementation on Markers of Inflammation in Adults with Cystic Fibrosis Hospitalized for a Pulmonary Exacerbation. This is from European Journal of Clinical Nutrition, 2012. They randomized 30 adults with cystic fibrosis who were hospitalized with a pulmonary exacerbation to receive either placebo or a bolus dose of 250,000 international units of vitamin D3. Remarkably, they showed a 50% reduction in tumor necrosis factor alpha and a trend for a 65% reduction in interleukin-6. They didn't measure any clinical parameters, but overall what they found is exactly what we would want. We would want a reduction in inflammatory cytokines, interleukin-6 and tumor necrosis factor alpha, also an increase in anti-inflammatory interleukin-10, and also an increase in the antimicrobial peptide LL37. So let's take a look at some of the details in their table number 1. As you can see here, interleukin-10 started at 42. 1 week later, it was 30. So their interleukin-10 went down. That's because these patients were acutely ill. So you would expect it to go down. The bolus dose of vitamin D wasn't effective at that time. But 12 weeks later, they may have seen some benefit from the vitamin D, at which point their interleukin-10 increased from 42 to 49. Likewise, tumor necrosis factor alpha reduced from 55 down to 27, so that's about 50% reduction. And also look at the antimicrobial peptide LL37, started at 73 and then increased to 142, so that's a doubling of their antimicrobial peptide production. So overall, I think this is a very positive study. Obviously, their utilization of 250,000 international units as a bolus dose is very suboptimal, so with a better supplementation program, I think the results would have been more positive and certainly more consistent with good modern clinical practice. Let's take a look at this study from Cytokine 2015. Supplemental vitamin D increases serum cytokines in those with initially low 25-hydroxyvitamin D levels, a randomized double-blind placebo-controlled study. So in this study of approximately 50 healthy adults, 46 healthy adults, they received either no vitamin D, 4,000 international units, or 8,000 international units. The benefit of the vitamin D supplementation was increased in interferon gamma levels and interleukin-10 levels. So this gives them more immune function, but also better anti-inflammatory modulation of that immune function. No clinical parameters were measured, and the summary is that supplemental vitamin D increased interferon gamma and interleukin-10 in subjects that were vitamin D deficient. We would expect this to translate to enhanced antiviral immune defense, coupled with enhanced control or modulation of that inflammatory response. And I think that we would all agree that that's exactly what we want. We want more antiviral defense, and we also want enhanced control or modulation of that inflammatory response. So now we're going to look at the effect of vitamin D administration on C-reactive protein and interleukin-6 in patients with ventilator-associated pneumonia. This was published in Journal of Critical Care, 2018. In this clinical trial, 46 adult patients suffering from ventilator-associated pneumonia and vitamin D deficiency were enrolled. The first group of patients received a single intramuscular injection of 300,000 international units. The other group received placebo. The inflammatory marker interleukin-6 was significantly reduced, and C-reactive protein levels also showed a trend toward improvement. The mortality rate among patients treated with vitamin D was significantly lower, so they showed biochemical improvement along with clinical improvement. So my summary is excellent clinical benefits, reduction in interleukin-6, and a good trend for the reduction of C-reactive protein, plus obvious safety and affordability. So I think we can endorse this treatment for use, even though obviously the bolus dosing is not anywhere near ideal. Now we're going to take a look at this systematic review and meta-analysis. Title of this article is Vitamin D Supplementation for Improvement of Chronic Low-Grade Inflammation in Patients with Type 2 Diabetes. This was published in Nutrition Reviews 2018. This is a meta-analysis of 20 randomized controlled trials with a total of 1,270 patients. Overall, the results showed that vitamin D supplementation reduced C-reactive protein, tumor necrosis factor alpha, and ESR. Some individual studies also showed increased in interleukin-10, NRF2, and adiponectin, along with reductions in interleukin-1, interleukin-6, interleukin-8, and NF-kappa B, all of which, of course, are inflammatory markers. They did not look for clinical effect here. They were simply looking at inflammatory markers. And their summary states, in summary, this meta-analysis provides level 1 evidence of the beneficial effect of vitamin D supplementation on inflammatory markers in type 2 diabetes. Larger and longer-term clinical trials are needed to establish whether improvements in inflammation following vitamin D supplementation would result in clinically meaningful health outcomes for these patients. So certainly we would expect benefit, but at least here, when they only looked at inflammatory markers, they showed clear evidence of anti-inflammatory benefit. So before we leave this study and move on to the next, let's take a look at one of their tables showing clear benefit favoring vitamin D for the reduction of C-reactive protein. And we can see the same thing here for tumor necrosis factor alpha, a clear favoring of vitamin D supplementation for both of these inflammatory markers. And tumor necrosis factor alpha, we know, is not simply an inflammatory marker, but it's a pathologic factor. It actually promotes inflammatory disease, tissue damage, and viral replication. So it's not simply a marker of inflammation. It actually participates in tissue damage and clinical disease. So you can tell from the following study that right from the start, we're going to have a few problems with the clinical application of this data. Even though it appears clean, let's look at the patient population. So a pilot study, the title of this article, a pilot study of the immunological effects of high-dose vitamin D in healthy volunteers. Well, that's nice, except for the fact that in clinical practice, none of us work with healthy volunteers. So on the one hand, we might expect to get some clean data from this. However, on the other hand, who exactly would we apply this data to if in clinical practice we typically see patients who are ill? But nonetheless, let's of course take a look at it. This was published in a journal called Multiple Sclerosis in 2012, December. The intervention among 4 healthy individuals is that they took either 5,000 up to 10,000 international units per day of vitamin D over 15 weeks. And this occurred to me as a bit strange because they had 4 individuals in the study, yet they had 11 authors on the paper. So they actually had more authors than subjects. After 15 weeks of vitamin D supplementation, the serum 25-hydroxyvitamin D levels rose significantly from baseline, with a corresponding increase in interleukin-10 production by peripheral blood mononuclear cells and a reduced frequency of Th17 cells. So you'll see that as this conversation advances today, toward the end of the presentation, I actually talk about that important balance. What we're aiming for here generally is to reduce the inflammatory markers, mediators, and inflammatory cells, including the Th17 cells, and to increase the anti-inflammatory and the immune modulating effectors, which are the T regulatory cells and interleukin-10. Summation of the study: more interleukin-10 is great and less Th17. Th17 cells are the pro-inflammatory cells that tend to participate in exaggerated inflammatory responses and autoimmune diseases. And we'll take a look at the ex vivo results, which I noted here as being notably robust. If you look at their interleukin-10 production, it rose from down here, let's say 200 or 100 units, up to this level, which is at least 500, up to 800, and even 1,000 units. So that again was their interleukin-10 levels. If we look at their interleukin-10 production in this model, again starting down here from below 200 and then rising up here to 750, and in this case, let's call that about 550 or 600. And again here in this ex vivo model, interleukin-10 production rose from relatively low, let's call this 200, maybe less than that, and here we are at 500, rose to 500 and about 800 respectively. So those are indeed numerically significant and likely also to be clinically significant. Short-term effect of high-dose vitamin D on the level of interleukin-10 in patients with multiple sclerosis. This was published in Neuroimmunomodulation in 2015. 94 patients with relapsing or remitting multiple sclerosis were randomized to receive 50,000 international units of vitamin D every 5 days for 3 months. So overall, the results show that the interleukin-10 level increased significantly after receiving high-dose vitamin D for 3 months. And the corresponding conclusion reads, interleukin-10 levels increased significantly in relapsing remitting multiple sclerosis patients after taking high-dose vitamin D3 for 3 months. No clinical parameters were monitored, and my summary is a statistical increase in interleukin-10 following vitamin D at 10,000 international units per day, and this is certainly in accord with clinical benefits along with other benefits on the microbiome and brain and neuroinflammation, etc. Even though this particular study did not look at clinical effects, other studies have shown that vitamin D is clinically useful, not simply biochemically useful, but clinically useful among patients with multiple sclerosis. Let's look at a different population here. This is 2 different doses of oral vitamin D supplementation on inflammatory markers and maternal and neonatal outcomes. This is published in Maternal and Child Nutrition 2019. The pregnant women in this study received either 1,000 international units or 2,000, both of which are insufficient. Testing revealed no effect on C-reactive protein, but significant reductions in tumor necrosis factor alpha, interleukin-6, and interleukin-1. Very important overall benefits for mom and child. And so this is obviously a very complex and dynamic study group because these are pregnant women who are in the process of giving birth to their children. The results show overall benefits for mom and baby and reductions in tumor necrosis factor alpha, interleukin-6, and interleukin-1. Again, such low doses of vitamin D are difficult to justify and are clearly insufficient, as we have known since 2004. This study from Immunobiology 2019. So let's look at what they did here. Predictive role of the interleukin-17 and interleukin-10 ratio in persistent asthmatic patients on vitamin D supplementation. So they had a very large patient population here of almost 200, 172 asthmatic Egyptian patients. Unfortunately, they received bolus dosing as 300,000 international units of vitamin D3 intramuscularly. This only raised their vitamin D levels from 17 to 25 nanograms per milliliter. So this is very deficient and still very deficient at the beginning and the end of the study. Testing showed reduced interleukin-17 and increased interleukin-10, allowing for the assessment of the ratio between interleukin-17 and interleukin-10. So that's a pro-inflammatory marker ratioed against an anti-inflammatory marker. Clinically, they showed improved lung function, and so the summary is exactly what we would expect. Let's look at this summarizing table here. Vitamin D levels increased from about 17 to 25, so this is very deficient and still quite deficient here. You can see that these 2 markers here of lung function actually improved. Their serum interleukin-17 level reduced from 18 down to 8, and their interleukin-10 level increased from 6 to 9. Now, when you look at the ratio between their interleukin-17 and interleukin-10, it started at 3 and then went down to slightly below 1. So looking at that ratio will probably increase our sensitivity to perceiving the benefit of reducing this inflammatory mediator, at the same time increasing this tolerogenic or anti-inflammatory mediator. Now let's look at short-term high-dose vitamin D supplementation for COVID-19 disease, a randomized placebo-controlled study. This was published in Postgraduate Medical Journal 2020 in November. Let's look at their table number 2, change in the levels of serum inflammatory markers. We see that their vitamin D level increased significantly. The D-dimer level in the vitamin D group decreased by 80, whereas in the control group it only reduced by 31. In the vitamin D group, fibrinogen levels reduced by 0.9. In the control group, they reduced only by 0.04. C-reactive protein reduced by 0.3 in the vitamin D group and didn't reduce at all in the control group. Patients in this study received 60,000 international units of vitamin D for only 7 days, and this was barely sufficient, as obviously not all of the patients were able to reach the target of 50 nanograms per milliliter, which is exactly the optimal range that I've recommended now for the past several years. Again, laboratory testing showed reductions in fibrinogen, C-reactive protein, and D-dimer, along with a reduction in COVID-19 positivity, showing a reduction in viral load. No clinical outcomes were measured here. Summary, the statistically significant reduction in fibrinogen with vitamin D supplementation among these coronavirus 19 infected patients suggests any or all of the following: antiviral benefit, anti-inflammatory, or anticoagulant, which would be more accurately described as an anti-hypercoagulation effect. And again, the 60,000 international units that they used for 7 days was clearly not sufficient to achieve biochemical optimization of their 25-hydroxyvitamin D. Again, here we have another study of vitamin D supplementation on lipid and inflammatory profile in healthy adolescent boys. This was published in Nutrients in 2020 of April. These subjects received 50,000 international units monthly for 6 months, so that's roughly 1,500 international units per day. No clinical effects were measured, but the results showed that tumor necrosis factor alpha receptor 2 concentration declined with vitamin D supplementation, while interleukin-10 levels increased in response to the vitamin D. So again, in this study, they didn't measure tumor necrosis factor alpha directly, but what they looked at is the TNF receptor, which actually amplifies the effects of tumor necrosis factor alpha. So again, what they did in this study is look at a unique ratio along with vitamin D status improvement from 24 to 41 nanograms per milliliter. They showed improved balance between the tumor necrosis factor receptor and interleukin-10. Let's look at a quote from this article. It seems that the relationship between inflammation and vitamin D status is reciprocal. Some researchers reported that inflammation reduces vitamin D concentration, while others showed that increasing vitamin D status reduces inflammation, and both of these seem to be right. Inflammation decreases the vitamin D concentration via oxidative stress induction. Oxidative stress activates vitamin D catabolizing enzymes and disturbs the biosynthesis of the vitamin in the liver. On the other hand, vitamin D itself has potential to decrease inflammation. So this goes back to what I had said at the start of today's presentation, and that is we see a vicious cycle here of vitamin D deficiency predisposing toward inflammation. Inflammation actually promotes the catabolism or loss of vitamin D. So again, we want to break that cycle with vitamin D supplementation. The next article is high-dose vitamin D supplementation improves microcirculation and reduces inflammation in diabetic neuropathy patients. This was published in Nutrients, 2020 August. The interventions were either 5,000 international units of vitamin D per week, which of course is very ineffective. That's less than 1,000 international units per day. The other group received 40,000 international units, and that's roughly the equivalent of 5,000 international units per day. Testing revealed a decrease in pro-inflammatory interleukin-6 and an increase in anti-inflammatory interleukin-10. The clinical benefit included a significant decrease in neuropathy severity and also an improvement in blood flow measured as cutaneous microcirculation. So again, in summary, 40,000 international units per week, which comes out to about 5,000 international units per day. For 24 weeks, improved clinical manifestations, cutaneous microcirculation, and inflammatory markers in patients with type 2 diabetes and peripheral neuropathy. Now let's take a look at this meta-analysis. This is the effect of vitamin D supplementation on rheumatoid arthritis patients, a systematic review and meta-analysis. This was published in Frontiers in Medicine, 2020 October, and the authors here provided a meta-analysis of 6 studies, only 2 of which provided reasonable physiologic dosing, as you can see in my notes here. So 50,000 international units per week in these 2 studies, that's mostly physiologic, but 500 international units is clearly insufficient, and the other 2 studies used bolus dosing, which we would expect would at least be suboptimal, if not completely ineffective. Different studies used different methodology in terms of laboratory testing, but overall they showed clinical benefit. So my summary here states vitamin D consistently shows benefit against various autoimmune disorders. That's very true, despite the fact that we're using very heterogeneous data. And as I've stated elsewhere, autoimmune patients should all receive optimization of their 25-hydroxyvitamin D levels for pain control, infection control, and anti-inflammatory benefits. Here's a study published this year, effects of 2 weeks of 5,000 international units versus 1,000 international units of vitamin D supplementation on recovery of symptoms in patients with mild to moderate COVID-19. So this was published in Nutrients in 2021 June, And again, the patients received 2 weeks of either 5,000 international units per day or 1,000 international units per day to measure the effect on recovery of COVID-19. So let's take a look at this data. Patients supplemented with 1,000 international units actually showed lower levels of 25-hydroxyvitamin D, indicating that the subphysiologic dose was inadequate and perhaps also that they were catabolizing the nutrient in their immune and inflammatory pathways. Even the group that received the higher dose of 5,000 international units per day was still horribly deficient at the end of the study. Their levels increased to only 25 nanograms per milliliter, which I consider to be horribly deficient and consistent with osteomalacia and immunosuppression. Interleukin-6 was the only marker that reduced significantly more in the 5,000 per day group relative to the 1,000 per day group. Other markers, including D-dimer, ferritin, and C-reactive protein, showed greater reductions in the 1,000 unit per day group, possibly reflecting what I had said before, either anergy or suppression of protein synthesis. The clinical benefit is that 5,000 international units per day of oral vitamin D3 supplementation for 2 weeks reduces the time to recovery for cough and gustatory sensory loss among patients with suboptimal vitamin D status and mild to moderate COVID-19 infection. So my summary states that 5,000 international units per day helps to alleviate post-COVID-19 cough and ageusia, that is loss of taste sensation, but is inadequate to normalize vitamin D status. And let's also note that inflammatory markers D-dimer, ferritin, and C-reactive protein do not correlate with clinical improvement, while interleukin-6 does. Notably here, the authors did not measure modulatory interleukin-10, which may have helped provide additional insight and explanation. So now let's take a look at this review article where they looked at the effect of vitamin D supplementation in patients with multiple sclerosis, lupus, Addison's disease, and Crohn's disease. So obviously all of these are considered inflammatory autoimmune diseases. This was published in Journal of Clinical Translational Research in 2021 in June. The vitamin D dosages varied in each of the studies, some of which were reasonable, but none of which were ideal. Again, these are all patients with autoimmune conditions, multiple sclerosis, lupus, Addison's, and Crohn's disease. Test results showed regulation of activated T cells and monocytes with B and T cell homeostasis successfully restored by increasing Tregs and decreasing Th1, Th17, and memory B cells. Other immune cells also shifted toward an anti-inflammatory phenotype. So they only looked at immune markers in this study. They didn't look for clinical effects. So my summary here is consistent anti-inflammatory immunomodulation in various autoimmune diseases. We're going to continue to look at this same study. We're going to look at a different table from the same review. These are patients with colon cancer, type 2 diabetes, and patients with renal failure receiving treatment with dialysis. The testing here again showed a reduction in all common markers of inflammation, C-reactive protein, tumor necrosis factor alpha, interleukin-6, interleukin-1, and interleukin-8. Again, in the cancer patients, they showed a reduction in the overall inflammation score. In the diabetic patients, they showed a reduction in C-reactive protein, fibrinogen, interleukin-6, interleukin-1, and increased IgM and adiponectin, suggesting improved immune function and also improved metabolic health. In the dialysis patients, they showed immunomodulation with reductions in C-reactive protein and interleukin-6. They didn't look for clinical effect here, they just looked at inflammatory markers. So in all of the groups, they showed consistent anti-inflammatory benefits in these patients with various metabolic diseases. So that actually brings us to the end of the major part of the review where I mostly focused on newer data showing an anti-inflammatory effect. What we're going to do right now is focus on a subsection of that data that looked really more specifically at the induction of T regulatory cells. So again, these T regulatory cells help to suppress inflammation naturally. So if we can engage or recruit the body's own anti-inflammatory mechanisms by using vitamin D, then we wouldn't have to spend so much time, energy, and eventually money on anti-inflammatory drugs because we would be recruiting the body's own internal anti-inflammatory mechanisms to suppress or modulate that inflammatory response. So I'm sure many of you remember looking at this image from my book, which I first published back in 2012 under the title of Functional Immunology and Nutritional Immunomodulation. So with regard to one aspect of the immune system, we start with these undifferentiated Th cells, and in a pro-inflammatory environment, these are going to get recruited to produce Th2 cells, which promote allergy, Th1 cells, which promote cell-mediated inflammation, or Th17 cells, which generally promote autoimmune type inflammation. So obviously we don't want any of those. With the use of certain nutrients like vitamin A, vitamin D, and probiotics, we can promote the differentiation of these Th0 cells into T regulatory cells, and those are the ones that actually promote tolerance, immune modulation, anti-inflammation, and interleukin-10 production. So when we measure interleukin-10 production following vitamin D supplementation, as we did in many of these studies, we're actually looking at that as a surrogate marker for the increased number and function of these T regulatory cells. So let's take a look at some of that original clinical data. This was published back in 2010 in the Israeli Medical Association Journal. Patients received vitamin D and they had a significant increase in the number of T regulatory cells. So my corresponding summary states significant increase in T regulatory cells, which generally correlates with anti-inflammatory immunomodulation. Let's look at another study here from PLOS1, 2010 December. Safety and T-cell modulating effects of high-dose vitamin D3 supplementation in multiple sclerosis. These were 15 patients with multiple sclerosis given vitamin D3, 20,000 international units per day for 3 months. That's a very reasonable dose for a somewhat short duration. Testing revealed increased suppressor T cells, increased proportion of interleukin-10 producing T cells, also some improvement in T regulatory suppressive function in some of the patients, not all of them, and a trend toward what they called an anti-inflammatory cytokine profile, and again, evidence of increased production of interleukin-10. So again, clear evidence of anti-inflammatory nutritional immunomodulation. Let's look at another study here from Arthritis Research and Therapy, 2012. Restoration of regulatory and effector T-cell balance and B-cell homeostasis in systemic lupus erythematosus patients through vitamin D supplementation. Patients received generous doses of vitamin D for 6 months, and they showed a significant increase in regulatory T cells, those are the Tregs, and a decrease in the effector Th1 and Th17 cells. Vitamin D also induced a decrease in memory B cells and a reduction in antinuclear antibodies. The clinical benefit was that these patients had no flares of their disease during the 6 months of treatment. So this provided clear evidence of anti-inflammatory immunomodulation with a suggestion of clinical benefit. And further supporting the benefit of vitamin D against autoimmune diseases was this classic article published in The Lancet in 2001 November, Intake of Vitamin D and the Risk of Type 1 Diabetes. The intervention here was a recommended 2,000 international units per day for 10,000 neonates and infants during the first year of life, and the follow-up phase of the study was for an amazing 30 years. What they showed here is a 78% reduction in type 1 autoimmune diabetes with a dose-response relationship. So the infants who received the full dose of 2,000 international units per day had more protection, whereas the children who did not receive the 2,000 international units per day had less protection. And so this is a truly remarkable study that was completely ignored by the profession of medicine. As I state here, this study met all criteria for a paradigm-shifting effect in medicine but was completely ignored. It was published in a leading journal, The Lancet. They used reasonable treatment. They had a huge patient group of more than 10,000 infants, and they followed these patients for 30 years. Furthermore, the clinical benefit was gigantic at a 78% reduction in type 1 autoimmune diabetes, and they showed a dose-response relationship, which again implies causality. So this single study should have changed the face of medicine, but again, it was completely ignored. So my personal commentary here is that failure to use population-based vitamin D supplementation is perhaps the best single example of nutritional neglect as medical malpractice, as sustained by governments and medical organizations despite overwhelming evidence in support of its use per its manifold benefits, also availability and affordability. So my general summary is as follows. We see that this information is published in respectable journals in general medicine and in specialty medicine. We see that various vitamin D3 dosages show safety. We know that they are widely available and clearly affordable and highly efficacious. Low and bolus dosing is clearly inferior, yet can provide significant clinical benefits, even though it's imperfect. Overall, we see reductions in C-reactive protein, fibrinogen, interleukin-6, interleukin-1, and tumor necrosis factor. And at the same time, we know that in the background of many of these studies, even when they didn't measure, we see elevations in T regulatory cell number and function, and increases in anti-inflammatory interleukin-10. Many of these studies looked only at inflammatory and immune markers. However, when the clinical effects were assessed, they nearly always show clinically important alleviation of autoimmune, metabolic, inflammatory, and infectious disease, especially viral infections. So again, consistent anti-inflammatory immunomodulatory benefits with improved clinical outcomes. As noted previously in videos number 1, 2, and 3, we also see alleviation of pain, depression, anxiety, and vulnerability to infection and allergy via weakened barrier defenses. Those barrier defenses are strengthened in every aspect by vitamin D supplementation. Absolutely no justification exists for allowing huge portions of the population to remain vitamin D depleted and thus suffering with pain, mood disorders, inflammatory and infectious disorders when we have the knowledge and ability to alleviate this unnecessary suffering right now. And we've had this ability now for at least 17 years, since around the time that I published the 2004 monograph on vitamin D. At that time, we concluded, until proven otherwise, the balance of research clearly indicates that oral supplementation in the range of 1,000 international units a day for infants, 2,000 international units per day for children, and at least 4,000 international units per day for adults is safe and reasonable to meet physiologic requirements, to promote optimal health, and to reduce the risk of several serious diseases. Again, safety and effectiveness of supplementation are assured by periodic monitoring of serum 25-hydroxyvitamin D and serum calcium. We proposed the optimal range at that time to be between 40 and 65 nanograms per milliliter, otherwise indicated as 100 to 160 nanomoles per liter. I also concluded that monograph by stating, given the depth and breadth of peer-reviewed research documenting the frequency and consequences of vitamin D deficiency, failure to diagnose and treat this disorder is ethically questionable and is inconsistent with the delivery of quality science-based healthcare. Failure to act prudently based on the research now available in 2004 in favor of vitamin D supplementation appears likely to invite consequences such as the COVID-19 pandemic, which according to this article and several clinical trials could be alleviated by 70 to 90% simply by using competent vitamin D supplementation. We have clear clinical evidence now that we need to be supplementing the worldwide population with vitamin D3 in order to prevent complications from all of these conditions previously mentioned, and especially in this day and age, the COVID-19 infection. In a recent clinical trial published in Journal of Clinical Endocrinology and Metabolism in 2021, among 838 patients with severe COVID-19 infection, administration of vitamin D reduced intensive care unit utilization from 21% to 4.5%, indicating massive financial savings and also massive reductions in healthcare utilization, and also reduced mortality from 16% to 5%. That's a 79% reduction in death simply by using vitamin D. And we have all of the science and evidence that we need and that we're ever going to have for a treatment that only costs several dollars or several euros per year. The data has consistently shown that patients who are vitamin D deficient are more likely to succumb to COVID-19 infection, and once they do develop COVID-19 clinical infection, we can alleviate the consequences and mortality of that infection, again, by giving them vitamin D3. We know that this is an international problem that we need to address, and we already know exactly how to address it. We can address it clinically with history and objective findings on physical exam, but mostly what we need to do is either supplement patients or test their serum levels of 25-hydroxyvitamin D and see where they are on this scale, which is my updated version of what I consider to be the optimal physiologic range. Most patients in Europe are down here at the level of depletion, chronic pain, weakness, and increased risk of infections. We know that most patients in Europe are at this level of vitamin D status, which is complete depletion, leaving them susceptible to osteomalacia, chronic pain, weakness, and increased risk of infections. The typical level of vitamin D in Mediterranean European countries is below 20 nanograms per milliliter. That is absolute depletion of vitamin D. Governmental and medical organizations need to take action to address this problem and get patients into the optimal range, which they could do for literally pennies per day. And with that, I bring closure to this Part 4 video, Redefining Vitamin D Deficiency in Adults. Here I focused on inflammation, coagulation, and immunomodulation. Thank you very much for your attention.